Be brave to stand for what you believe in, even if you stand alone. Roy T. Bennett. Welcome to the Guyana Dialogue. I'm your host, Shamisa Ali. Good evening to everyone joining us on Facebook and on YouTube. Tonight's topic is State of Healthcare in Guyana, Accomplishments and Challenges. The Guyana Dialogue is being sponsored by a coordinating council of Guyanese based in the US, UK, Canada, the Caribbean. Funding support is by well-known philanthropist Dave Narayan from Dave West Indian Imports. Please welcome my moderator for tonight, Dr. Tara Singh.
Thank you very much, Shamisa, and
Our
welcome to our
panelists,
viewers.
good evening, Dr. Tara. Our panelists are Professor Muniram Budu and
Hello?
Dr. Gangaram Das.
Hello. Hello,
Good
everyone.
evening. Good evening. Our guest tonight is the Minister of Health, the Honorable Frank C.S. Anthony. Good evening, everyone, and welcome to the Guyana Dialogue. Dr. Tara. Dr. Tara, you can continue.
Back to Frank. Okay. Thank you very much, Shamisa. Welcome to Dr. Frank Anthony. I know you're very busy. We are very grateful to have you. Um, um, Doc, before the two other panelists, I think you may know them, Professor Muniram Budu and Dr. Ganga Ramdas. I think you have met them in a prior program. Um, I just want to make a few observations and then ask you a few questions and pass you on to the other panelists. I think it has been stated that you're planning to build 12 hospitals, of which 6 are regional and 1 is specialty at Ogle. And one of the questions raised is how do you intend to get staff for this? If you can comment on that. Dr. Anthony, you heard?
Yes, well, thank you very much for having me on the program.
Doc,
Um,
have you heard my question?
Hello?
Doc, Dr. Anthony, Dr.
Yeah,
Ganga, can you hear me?
Yes, I can hear you well.
are you hearing me?
Yes.
Dr. Frank, can you hear me?
Yeah, I can hear you.
Dr. Frank,
Yes, I'm hearing you.
my question is, my question was that your ministry is planning to build 12 hospitals, of which 6 are regional and 1 is specialty hospital at the Ogle. Now, the question that is being asked by people, how do you intend to staff these hospitals? From where you'll get your staff and the other resources? Can you comment on that, please?
So, again, thank you very much for having me on this program. Um, First of all, we are building 6 regional hospitals. So they're right now under construction. We have one such hospital being constructed in Lima on the Esquivel Coast, one at Dikendren, one at Diamond, one at Enmore, one at Bath, and one in Skeldon. So these are 6 regional hospitals that we have. In addition to that, we have a new hospital under construction at New Amsterdam and a new maternal and pediatric hospital in Ogle. In addition to these 8 hospitals, we have a project that has started, and very soon we will start the construction of a hospital in Maruka in Region 1, Keto, Camarang, and Lethem. So these are at various stages of the bidding process, and very soon we should get the contractors for these. Now, while we're doing the construction, we are also doing the manpower planning. And one of the areas that we have looked at is the area of getting nurses. And so we have created a hybrid program with the assistance of a university in Brazil, the San Paulo University in Brazil, with the Pan American Health Organization. And we have devised an online course. And with this online course, we'll be able to provide the theoretical training for the nurses. And once they've completed that, we have already built 10 simulation labs across the country. So the nurses would be able to come in and do their practicals in these simulation labs before going to the hospital. So in the first batch, we have 1,200 nurses in training. And we are going to have another intake of nurses in September of this year. In addition to registered nurses, we have also been training nursing assistants. And right now we have about 800 nursing assistants in training. So we are cognizant that with opening new facilities, we'll need to have additional human resources. And that is why we have emphasized our nursing training. With the doctors, while we have been graduating a number of people in the undergraduate programs, we have also developed over the years a postgrad program where we have more than 18 different specialities. And so people can get specialized training in Guyana at the Postgrad Institute. We have also entered into partnerships with a number of hospitals and universities abroad. One such partnership that we have is with McMaster's in Canada. And we have been, over the next 3 to 4 years, our intention is to send at least 30 persons to specialize in various fields, and they'll come back to Guyana. The government of Guyana is paying McMaster's for these training. We have also recognized that with the new facilities, and even with the ones that we have to train healthcare administrators. So we have graduated the first batch of 25 healthcare administrators. And this is a program that we have done jointly with York University in Canada, the Schulich Business School. We currently have another 25 that is undergoing training. In addition to these persons, we have taken physicians and we are giving them training in leadership and how to manage their departments and wards. So there are 25 physicians right now that are undergoing such training, and that training is also being provided by York University. We also have a partnership, as you would know, with Mount Sinai, and there are different aspects of health that we are working with them on, including primary health care, development of some very specialized types of care in the area of cardiovascular care and oncology. And we also have a partnership with Norway, where they are sending residents to Guyana to be trained, and we send persons from Guyana to do observerships at Northwell. So there are lots of things that we're doing that would enhance the capacity for our healthcare to be able to deliver quality care here in Guyana. And you probably would have noticed over the last year or so that we have been doing some groundbreaking work, things that were previously unheard of in Guyana. So, for example, we did a valve replacement for a heart. That was done about a month and a half ago. We have been able to do surgeries for aneurysms and a whole host of other complicated things. And this is because of the training that we're investing in, plus the kinds of equipment that we have been providing to our doctors. So while we build out the infrastructure, we are also planning to make sure that we have adequate human resources to manage these infrastructure.
Mm. Okay, Doc. I just want to switch you over. Something has been in the news recently: life expectancy. The president, in his speech, has stated that life expectancy has jumped 2 points from since you all took office in 2030 to now. As a matter of fact, the average life expectancy is 70, with women being 74 and men being, I think, less than 70. There's a good quality of life issue that is often neglected when people do economic analysis, and also the rate of infant mortality. That is another indication of either good, medium, mediocre quality of life issue. But those are very important, including weight loss. Can you comment on that
Sure. I
briefly?
mean, one would expect that expectancy is going to climb because of the investments that we're making. We've seen a decline in infant mortality. And if you have high infant mortality, obviously the life expectancy is going to be lower. But not only have we decreased infant mortality, but we have also decreased neonatal mortality, meaning that for the first 7 days of life, that we're having less children dying in the first 7 days of life. And that's because in the past, we only had one neonatal unit at the Georgetown Hospital. But we have now been investing in developing regional neonatal units. So all our regional hospitals, they now have neonatal units, and we have trained the doctors and nurses to be able to man these neonatal units. You might know that we have developed a pediatric program where we're training our doctors, and so once they're trained, they go out to these different facilities to provide better quality pediatric care. That program, too, we have been able to run with a Canadian NGO along with one of the universities in Canada. So the program is highly accredited, and the people who um, come out from the pediatric training, they will get a UG certification. So, because we have specifically looked at building the infrastructure out and providing more neonatal units and train people to operate these units, we are seeing less deaths for neonates. And we are seeing, because of the strong programs that we have, less children dying below the ages of 1. And this, obviously, if you can reduce this, it would have a definite impact on your life expectancy. But it's not only life expectancy that we're looking at. One of the things that we want to do is that if we add more life to people, meaning that they're living longer, we want them to live longer, but they must have a healthier life. So, along with life expectancy, we want to make sure that their health expectancy or their health span is increasing so that you will live longer with better health. And so that too is very important because you don't want to extend life expectancy, and for the last 10 years of people's life they're very sickly. That's not what we want. So we're trying to combine two things here. You must live longer and healthier, and you must have that very long life. And that's what we're working on. And many of the programs that we are also looking at, it has this life cycle approach. So while we just talk about neonates and on the 1 and on the 5 and so forth, the government has introduced a program called a school health program. Um, and I think we are one of the very few countries that offer such a program in the world. What we are doing is that every child that enter the school system, we are screening these children. So we do screening for your eyes, and if you have a problem with your sight, and it can be corrected with spectacles, then the government would provide that spectacles for that child. If the child has a problem with hearing, then we provide hearing aids. If the child, when we check the mouth, if there are problems with their teeth, then we can fix that because they'll come to one of our dental units. And we do a general checkup for the child. So this is happening at nursery. So far, we have completed close to 20,000 nursery school children who have been screened. And we have identified a number of issues and we are fixing those. And once we complete the nursery schools, we are now going to go to primary schools where we estimate maybe about 200 and something thousand children that we will be screening at the primary level. Once we completed primary, we'll then go to secondary. So over the life of a child, we are ensuring that we screen them at least 3 times. And so if we pick up things early, we'll be able to address them early. So this is in keeping with this lifestyle approach and in intervening at every stage to make sure that people live longer and healthier lives. So the ministry is not just about um, treating people when they get sick. A lot of our work is now trying to keep people, let them stay healthy. And the only way we can do that is to promote screenings, make sure that we identify issues early and we intervene early so that we prevent a lot of the complications that come with late diagnosis.
Okay, Doc. Thank you very much, Dr. Ganga.
Thank you, Dr. Anthony. I think your report card deserves an A. It deserves an A. I've listened to you carefully. You talked about infrastructure. I'll ask a question there later. Services, access to the services. I will ask you to refer to that. Training, you get the A plus plus on that. I'm very impressed, and the new direction of preventative health care that you just mentioned, that's a big plus because that would lower costs, and healthcare costs is very, very important because that will determine access. So I looked at the population distribution. I noticed we have region 4 highly populated, then you have region 5 and region 3. Can you comment on the distribution of first the infrastructure and then the number of hospital beds in these densely populated regions?
So if you take Region 4, where we have most of our population, it used to be serviced primarily by the Georgetown Public Hospital. So that hospital functioned as the national referral hospital, but it's also the regional hospital for Region 4. And very often you will have a lot of congestion at the hospital because of the varying services that it would offer. What we are trying to do by building a regional hospital now at Diamond and building one at Enmore, we are actually going to decant the services on the 2 corridors in Region 4 so that people living on the east bank of Demerara, they don't need to travel anymore to come to Georgetown once the hospital is completed. The hospitals that we're building, these regional ones, they cater for, they'll have a 24 hours accident and emergency. They'll have a complete diagnostic suite, which includes imaging. And that's not just x-rays and ultrasounds, but you will also be able to get CT scans at any one of these facilities. We'll have a full 24-hour lab services. And then we have a 75 inpatient bed capacity at each one of these hospitals. We will also have 3 operating theaters, 2 of them being a major theater and a minor theater for small things like lacerations and so forth. So when instead of people having to travel along the East Bank to come all the way to Georgetown, you go to Diamond because all the services that you would have otherwise gotten at Georgetown, you'll be able to get at Diamond. And so that's going to take a lot of the traffic from the Georgetown Hospital so that it can function more as a national referral hospital. And similarly on the East Coast, that's what's going to happen. In Region 5, the other region that you mentioned, currently we have two hospitals that are operating in that region, one at Myconi and one at Fort Wellington. Fort Wellington does not have a surgical theater. So, and that has been forever. I mean, since they constructed Fort Wellington, it did not have surgical capabilities, nor did Myconi. So, in the whole of Region 5, they didn't have um, theater capacity. So, if someone had a major accident and you needed to go into the theater to do an operation, that was not possible. You had to move these patients from Region 5 and bring them either to Georgetown or take them over to New Amsterdam. We have changed that because at Myconi, um, last year we built a theater there. That theater is now operational. We are using it more for elective surgeries. So if you come in, you got a hernia, you got something, we would schedule your surgery, and we have a surgical team that would come in and do the surgery right at Myconi Hospital. Across from the Fort Wellington Hospital, we are now building another regional hospital, and that's going to have the three operating theaters and all the things that I mentioned for Diamond. It's going to be similar at Bath. So they now, for the first time, would have all these capabilities. And that's really a game changer for Region 5 because now they don't necessarily have to travel to go to New Amsterdam or go to Georgetown. You will have all the medical services that you need at your disposal. In Region 3, the big hospital there is the West Demerara Hospital. As you would know, that used to be the TB sanatorium many, many years ago, and that was then converted into a general hospital. So that serves most of the region. And again, there are lots of challenges because that hospital is a quite old hospital. What we are now looking at is looking at developing a modern hospital on that site, and those discussions are currently ongoing. But at the other end, and that is the end towards Parika, we have identified 14 acres of land and we have started construction of the Kendron Hospital. And that by the end of the year, early next year, would be fully operational. So right now, that would be able to service all the people coming out of the river and all those persons in the surrounding areas, Parika, Tushin, these big communities that have been built around there. And again, it would have varying capabilities so that we can provide better service for the population.
The the part that is also important in terms of lowering overall costs would be the location of training facilities.
Mhm.
That would lower the service, the individuals who want to be trained, the nurses, the assistants, and so forth. Their costs of travel and also access to the training labs and so forth would be for. Could you comment on how that's going?
So that's a very important question. So with the hybrid program that we've introduced, they don't need to travel. Once they have an internet connection at home, we're teaching them at home because the course is online, and we have a partnership with Coursera, and they have given us a portal. So our course is now on the Coursera platform, and we would give the nurses um, a password to get into that portal, and so they can do their theoretical training from home. Of course, with the applications that we have from Coursera, we are able to track who is coming to classes, who are completing their assignments, and a whole host of other features that we are using. So they don't need to travel. But while we are training them online, we are also giving them a stipend of $17,000. And so they can use that for whatever little expenses that they have. And once they complete their training and they're successful at their exams, we have guaranteed them a job in the ministry. So they're going to get a job with us. And the starting salary for a registered nurse, it would start at $165,000 per month. And that's a big improvement from where it was about around $80,000. And we have given that increase over the last year. So there's tremendous change that is happening in the sector. And we'll continue to make those innovations, investments, so that we can improve the services that we're delivering.
You did mention Brazil. How does that fit into the picture? The Brazil training with
So we have a
language problem.
partnership with the University of San Paulo, and their professors would come to Guyana and work with our professors so that we can upgrade the training that we are offering. And last year, we sent 25 of our professors in this nursing program to Brazil to see how they are training their nurses and how they've been utilizing this online hybrid type of platform so that they can now implement that here in Guyana. So these exchanges are very useful because if people haven't used these methodologies before, it can be challenging. So that is why we have given our professors that type of immersion. And we send them to Brazil, and I think they came back and they're doing a good job because we have right now 1,200 nurses who are in training on that program.
Thank you very much. Appreciate
No problem.
Dr. Tar.
Question to Dr. Frank.
Hello?
Yeah.
Dr. Anthony, yeah, you're involved in transforming the healthcare sector, and you have completed many projects and have several ongoing projects. Now, to give our viewers an understanding of these projects, which you've already started to, and there are a lot of them, I will ask you a series of questions, and I kindly request that you provide short, clear, and factual responses so that our viewers can get a clear understanding. Because when you talk a lot of these things, right, they tend to get confused with so much that you have going on. Now, how many new hospitals are you
So,
building?
so
Where
the
they
ones that, so the
where they
ones that,
located? Sorry,
uh
where
go
they're
ahead.
located? How many have been completed? How many in construction phase? And what services will they provide? That's for the new hospitals.
Right. So
Mhm,
let's start there.
mhm,
So new hospitals we have right now that are under construction, we have 8.
mhm,
So as I said before, one starting from Escribo, we have one in Lima that is under construction. In Region 3, we have one at Dikendren. In Region 4, we have 2. One at Diamond on the East Bank, one at Enmore on the East Coast. In Region 5, we have one at Bath, and in Region 6, we have one at Skeldon. So these are what we call regional hospitals that we're building, and they're all located on the coastline. So this is the first wave, if you like.
mhm,
We have also built referral types of hospitals, or we are in the process of building them. One is going to be located at Ogle, and that is a very specialized hospital for mothers with complication during pregnancy. And we also are catering for children with various types of complications. So it would be a very specialized children's hospital. So in any one of the specialty, whether it's orthopedics, whether it's cardiovascular, we would be able to provide that high quality of care at this children's hospital. In addition to this children's hospital, we are we are right now starting the construction. The foundation is being laid right now for a New Amsterdam hospital. And in that New Amsterdam hospital, it's going to be much bigger than the existing facility. The range of services are going to be far greater. And the range of services would include us being able to do cardiac um, interventions in the New Amsterdam hospital. So once it's completed, we'll be able to do open heart surgeries in New Amsterdam. We'll be able to do stenting and so forth. So a lot of different things we'll be able to do in New Amsterdam that we cannot do right now because we don't have those facilities right now. So all of these facilities right now are being constructed. The six that I referred to earlier, those are going to be completed the latest by the first quarter of next year, the latest. And the other two would be later in 2025. Well, the Ogle one would be later in 2025. The New Amsterdam, which is now starting, we'll see that being completed in 2026. So these are major infrastructural projects, and they are going to make a tremendous difference in terms of the quality of services that we'll be able to offer. Apart from these eight, we have now, under an IDB loan that we have gone out to tender for a number of additional hospitals. So one of those hospitals is going to be in Maruka in Region 1. Another one is going to be in Letem in Region 9. We'll also have one in Keto and another one in Cameron. So these are an additional four that we are building in the interior of Guyana. In addition to this four now, through a grant that we got from the Indian government, we are now going to do over the Bartika Hospital. And so this now is going to change what we have in Bartika. So as you can see, these investments that we're making is going to change the overall landscape of structure in the country. And the people in the interior would have almost similar facilities like those on the coastline because the equipment, the services, everything would be the same. And then we also are using connectivity so that if you do an X-ray in Region 9 and we don't have a radiologist in Region 9, we can upload that on the cloud and the radiologist in Georgetown Hospital can pull that down and look at it and give an interpretation so that the doctor in Region 9 would be able to understand what is happening with this patient. So that's the kind of use of technology that we are practicing that would lift the quality of care that we are providing. Now, as we are speaking right now, we are offering telehealth in a number of rural communities in Guyana. So we have 25 sites where we have telemedicine. So think about this. A community that is 600 kilometers away from Georgetown, that is isolated. If they have to leave there to go get health care, it might take them, I don't know, 5 days walking to the nearest hospital. So it's very difficult. But right now, through telemedicine, We have given them a computer. We have given them internet-enabled devices, and we link that computer to um, the satellite. So we have connectivity, and the computer is powered by solar power. And so what we're able to do now, if a patient come into one of those facilities and the community health worker does not know what is wrong with the patient, they can open their laptop and they can contact a doctor in any one of the hospitals. And that doctor would come online and guide them through an examination of the patient, help to make a diagnosis using the tools that we have on site. And so, for example, we are able to do an ECG, and the doctor in Georgetown would be able to see that ECG in real time. Or we are able to do an ultrasound, and they would be able to see that in real time. And therefore, by seeing that, they'll be able to make a diagnosis. And having made that, then a decision would be made whether we have to medevac the patient or whether we can treat that patient on site. So right now we are operating 25 such sites. In the next month, we are adding another 25 sites. And by the end of the year, we are hoping to have at least 80 sites across the interior of Guyana that where we would be able to offer this type of service. So it's a very innovative way of delivering high quality healthcare.
Yes. So you're building new hospitals, a lot of them. You're refurbishing and improving existing hospitals like Georgetown. And then you have these healthcare facilities, about 50 you probably will have soon. Is that correct? These
Yes,
clinics,
we'll
so-called.
have 50 telehealth sites
Uh-huh.
in the next month or two. And then by the end of the year, we'll have about 80. And
Uh-huh.
I just want to say this because we have spent a lot of money to upgrade health facilities in our country. So we have about 350 health posts and health centers.
Mm-hmm.
So that's what we are operating, 350 health posts and health centers
Mm-hmm.
across this country. And in every one of them, this government over the last 3 years would have spent money fixing them up, making sure that they have adequate equipment, and training people to be able to be there at these facilities.
Mm-hmm.
So we have trained a number of community health workers for health posts. So every health post now in this country would have at least two community health workers, right? That
Mm-hmm.
when we came in a couple of years ago, many of these places had zero. They had nobody, and
Mm-hmm.
the health post was in such terrible shape that nobody wanted to go there. And in this
Mm-hmm.
short period of time, we have fixed all of this. So you can go across Guyana and you would see almost brand new facilities because we have invested a lot of money in fixing these facilities and training people and make sure that people can have access to care. And I think when you go in any region, you would see that type of development in our country.
Now, do you have electronic healthcare services for record keeping appointments and the like? Because now you have your healthcare being spread out throughout the country.
So
Is that something you have?
that's a very good question. So one of the things that we did about 2 months ago, we have advertised for companies to come in and bid to do exactly that, to set up an electronic health record system. And
Mhm.
we had 14 bids. We have now narrowed that down to four. And very shortly, they would be asked to come in and set up demonstrations to demonstrate the systems that they want to provide. And then we'll make a decision. So this, we want to start at the main institutions, and then we'll roll this out across the country. But what we are going for is not just digitalizing the patient's record. What we are going for is something slightly different, meaning that once we set this up, let's say, at your Georgetown Hospital. When you're going to the Georgetown Hospital, you'll be able to go on your phone. There would be an app that you can download. And then from your phone, you'll be able to make an appointment with your doctor so that when you show up there, you don't have to wait a long time. You don't have to wait 2, 3 hours to see somebody because you would have a specific time slot. So you go there, you get to see the doctor. And then one of the biggest time wasters that we have is that when you show up, they'll have to take some time to go browse through all that paper file to be able to find your record. So we are converting that. You would have a smart card. And when you give the card to the health people there or swipe that card, it would give them access to your record. So they can pull up your record instantaneously. When you're seen by the doctor, all the information is going to be charted electronically. If they write you a prescription, that's going to be an e-prescription that goes to the pharmacy. So when you go there, your meds are going to be ready. If they need to do a lab test, they'll take off the sample, they send it to the lab. You don't have to go and line up at the lab to collect your results. That would automatically, once the results is available, it automatically goes back into your record. If you went and you did a CT scan, once that is completed, that image is going to go into your record. So that's the system that we're working on. And
Yeah.
once we are able to put all of that in place, it is going to be changing the way that we deliver care in a very, very significant way. But that's what we are
But
right
the-
now
yeah,
investing in and working on. And we already
yeah,
allocate the money to do that.
yeah. So we have the infrastructure. You are doing some training for your nurses and doctors and other staff, and I think quality is important. So you have to have data in order to evaluate that. For example, at the moment, do you collect patient to staff ratio, for example, nurse turnover rate, physician retention, and so on, time to treat patients, staffing hours, and
We have a
credential
lot of data.
upgrading? Do you have
We
those?
have a lot. So we have different type of data that we collect. We have those that
Hmm.
we use for management purposes,
Hmm.
and we have those that we collect to look at disease surveillance.
Mhm.
So if there's an outbreak of anything, we must be able to detect it. And we have been working with some of the best in the field to build out those surveillance systems. So, for example, in terms of surveillance, we've been working with Johns Hopkins. They have a system called SAGE. And
Mhm.
so we had a team down from Hopkins that came in and worked with the staff of the ministry. And very soon, we'll be rolling out this electronic surveillance system for diseases. So we would be able to detect anything, any part in Guyana. If there's any spike in cases, we would be able to see that. So whether it's malaria, whether it's leishmaniasis, whatever it is, we must be able to see it. And once we see it, if the numbers are getting too large, then we can send a rapid team to intervene to fix whatever is there. So that's one use of data. We also track data to know, so for example, all the work that we're doing in the school system. This is going to be done electronically as well, so that for every child in school, we'll be able to understand whether there's an obesity problem, whether there's a hearing problem, whatever it is, we'll be able to find that. And that's because we're using data to do the work that we do in the ministry. A Ministry of Health cannot run without data, and that's what we've been doing.
All right.
When we went through COVID, we could tell you where the patients are, which region, which hospital, which village, who was positive, and who was in the hospital, who needed oxygen. We can get to that granularity. Um, so yes, I mean, we have been using data to help us to improve the services. Can we do better? Obviously, we can do better. So this is something that we are constantly looking at, how we can improve the system.
All right.
So that's something we've been
Yeah.
working.
But statistics show that countries that grow richer, various healthcare issues that probably not present in Guyana at the moment. So is it obesity, depression, suicides, and so on, have increased. Do you have programs in place to diminish these issues as Guyana become richer?
Well, there's this concept of not just with a demographic transition, you also
Mhm.
have a shift in the burden of diseases.
Mhm.
Whereas you go through this process, there's a shift from infectious diseases to more non-communicable diseases.
Mhm.
And you're seeing that transition around the world. And in some cases, for some countries, you have both of them. So the burden is even higher. What we have been able to do in Guyana, we are mitigating a lot of the infectious diseases. And in fact, one of the programs that we have right now is to eliminate 5 different diseases from Guyana. So
Mhm.
things like leishmaniasis, filaria, leprosy, and so forth. We have programs where, for the first time in the history of this country, by 2030, these things are going to be eliminated from Guyana because of the programmatic efforts that we're putting in. So, as we reduce the burden of infectious diseases, we would then be able to move a lot of those resources across to non-communicable diseases. Now, we are not waiting until we eliminate. While we're doing that, we are also expanding the programs that we have for non-communicable diseases. So we have programs to deal with diabetes, for example, which is a major problem here. We have just completed guidelines. We have been implementing training. We have standardized the way that we treat our diabetic patients. We have pivoted away from these glucometers to using HbA1c, which is the standard in many places, including in the US. So that is what we have introduced to our population here. And we have bought the HbA1c machines so that we can do these at mobile clinics. So it's not where you have to now wait for a couple of days to know your HbA1c. We can do that in some of our clinics.
Mhm.
That's the level of um, how to put it. That's the quality that we're offering. So that's diabetes. In terms of hypertension, which is another major problem that we have in the country, we have been using a WHO protocol called HEARTS. And we have changed a lot of the medications out so that we have a far more effective medication in the management of hypertension. That has now been implemented in close to 150 different clinics across Guyana. And we are adding more clinics as we go. Every month we add a few more, right? So we have bought these meds. We are training people to use them, and we are putting them out there so that people can benefit from these newer medications that we have.
Mhm.
So that we are hoping to bring down and better manage our hypertensive cases, which can have an impact on your heart disease. Now, while we work on preventing some of these things from happening, last year, one of the things that this government did, we helped close to 850 patients that came into the accident and emergency with heart problems, meaning that they were having a heart attack. In the old days, those patients probably would have died because we didn't have the capacity to intervene. We weren't able to do an angiogram. We weren't able to do a stent for them. And in the old days, too, many of these patients, if they didn't have the money, if they went in the private sector and these things were available and they didn't have the money, they couldn't get service. So think about it. An angiogram would have been close to $250,000 Guyana. A stent probably 500, $600,000. Most people can't afford that. Last year, 800 people came to the accident and emergency at the Georgetown Public Hospital. And each one of them, whether they needed an angiogram or 2 stents or 3 stents, we, the government of Guyana, provided that for them free of cost. They didn't have to pay a cent for it. The government of Guyana paid for that.
Yeah, you know, the cost you
So,
mentioned is
and
rather
so
the
that's,
cost you mentioned just now
yeah.
is for me sitting in the US, that's pretty cheap. So is there any plan you have in Guyana to have a medical tourism hub?
Well, I'm sure once we complete these new hospitals that we're building,
Mhm.
that there are a lot of people who would want to come here for healthcare.
Mhm.
So a good example, and I think people need to understand the sophistication of health now in Guyana. So a good example, there was a patient from Grenada who had kidney failure and needed to get a kidney transplant, right? They
Mhm.
wanted to get a kidney transplant. They look at the United States, it would have cost them close to half a million US dollars to be able to get a kidney transplant in the United States. They came to Guyana with the donor, and we were able to do that transplant for them free of cost. So we do kidney transplants here, right?
Mhm.
And we have a whole team of people who have been trained to provide kidney transplants. Apart from kidney transplants, we have been doing corneal transplants, and we have done more than 100 corneas. So the level of and the quality of medicine here is changing. And when you talk about medical tourism, a lot of people would come here
Mhm.
because of the things that we are now doing in Guyana.
I hope it's not all for free. Um,
Well, we would probably have to
Okay,
look at the mechanism
Mhm.
because once people
okay.
do it for free, I guess
Dr. Budu, we just have a few more minutes,
All right.
and there are a few other
Mhm.
areas we need to touch before Dr. Frank goes off.
Okay, go ahead.
Dr. Frank, there was an outbreak of dengue fever. I don't know if it's malaria as well, but it was reported in the press that there has been significant levels of incidence of that. What measures are your ministry taking to curb or control this?
so. Dengue it's not only a Guyana problem. I'm sure you would know that from the news. Brazil right now, they um, at this time of the year, they have more than 6.3 million cases. 6.3 million cases in Brazil for the first part of the year. So this is something that we're seeing in South America, and in Guyana we have had increase in cases of dengue. So what we have been doing there's a combination of methods. We have distributed diagnostic rapid kits across the country so that anybody that fits the profile of a dengue patient, then we can do the test for them to confirm whether or not they have dengue or not. Because a lot of people with fevers and so forth might think it's a flu, they don't check. But now we are able to confirm because of the scale at which we're checking people. And that's why sometimes when you see the cases go up, it's because we're doing more testing. So that's one. We're doing lots of testing. The second thing that we're doing to control the mosquitoes and their breeding sites. If you have stagnant water, you are going to get breeding sites. We all know that. So we have to work with the various communities to remove these breeding sites. We have been providing to a lot of the NDCs a chemical called abate that would be killing the larvae in the water. So if we reduce the larvae, then we wouldn't get the mosquitoes. So that's something that we've been working on and working through is to be able to do that. We have also been doing a lot of fogging to kill mosquito, and we have been providing bed nets especially to people in the interior. And these are special bed nets. They are impregnated with insecticide. So if an insect lands on the net, it would kill the insect. And these nets can last for 3 years, and they're very effective. So we've been distributing this both to control the mosquito population, and depending on which mosquito, we can prevent dengue, we can prevent Zika, we can prevent any one of the mosquito-borne infections, and that's what we have been doing. But we need a partnership. It's not just government. It must be a combination of government and people, because people need to keep their environments clean. And we need to avoid these stagnant pools, which we have a lot of. So we have to have that partnership to be able to reduce this burden. Now, if people get with dengue, most people would be okay, but you'll have the occasional cases where people would have need to be hospitalized. And so once they come into the hospital, there's a whole protocol of what we'll do in the hospital. And in fact, in anticipating this, we have done a whole manual, and we have trained a lot of our doctors to be able to provide care for dengue patients, because we have been seeing the wave that is going through South America. So we've taken those precautions.
All right, thank you. The other thing is, I was speaking to a medical officer, a medical doctor who has vast experience, and he was telling me last night that some of the regional health centers, the physical amenities are really deficient. In some cases, he said a few of the buildings were leaking. Um, I know those may seem to be petty things, but it's very important that these things be fixed if they do exist. Are you
Well,
aware of this?
well, I would be happy for him to provide you with a list, and if you can send me that list,
Yeah.
because
Okay.
I I really I mean, maybe there might be one and two, but I really doubt that. And the reason why I doubt that is because last year, every single region in Guyana, just for health, the Ministry of Health would have provided them with more than 200 million Guyana dollars just to fix little things in health centers. So whether it's a leaking roof, whether it's fixing a toilet, we provided to each region $200 million. The year before, we gave them 100 million, right? So, in terms of providing resources to fix these things, it's there. So, I would really like to see that list of health
Okay.
centers where you have
Uh,
leakages, so
mhm.
that we can deal with that.
Yeah. He also pointed out the absence of some basic medications. Um,
That's not true,
that's not true.
and
Okay.
I can tell you that off the cuff,
Okay.
because right now we have more between 85 to 95 to 90% of all medications that are supposed to be in the system. That's the level of stock that we have at all of our facilities. So a couple of years ago, that used to be a complaint, not now. And I
Okay.
go to some of the most remote places in the country and I check for that. Just a couple of days ago, I was in a place called Hotokwai in Region 1. And one of the first things I did when I went there was to look at the health center, go into the pharmacy to see whether they have meds. And they had all the basic meds for that type of facility. So sometimes, you might have cases where people don't use the facility, but they assume that these are the problems that you'll have there. But we have substantially changed the landscape when it comes to availability of medication. And this government has been investing millions, well, not millions, billions of dollars to buy medicines for people. Billions of dollars.
Oh, okay, but you know there's a question. You can spend a lot of money to buy things, but the outcome, the output might not necessarily match the expenditure. There may be leakage in the system. But
Well, there can be leakage, but even with leakage, we have enough to make sure that at every health center, they are medication.
Okay. Um, Finally, Dr. Ganga, in a previous discussion we had with you, had suggested a policy and research unit in your ministry to compile data, analyze, and test the validity of data so the public can have access to that. Now, you have said that you're guided by data. You may have access to that data. I don't know how complete is that data, but a lot of people who have been doing research said they have a difficulty in getting data from your ministry and up-to-date data. If you look at the Statistical Bureau, which is supposed to be a clearinghouse for data in Guyana, you look at some of the indicators, they are way 3, 4 years back. Do you want to comment on that?
Well, I can assure you that in terms of diseases and that we track, that we do have up-to-date data. And so that's available in the ministry. We use that to guide our policy. I don't know what data maybe the Bureau of Statistics have, and I don't know what research questions people might have. If it's outside of the realm of what we collect routinely, well, then they would have to set up a study to be able to collect what they need for their research. So there's a different thing altogether. But outside of that, the stuff that I was describing as it pertains to what we are going to do in terms of digital health, in setting up a new digital health department, a lot of the data that we collect would be computerized and be available. And so, under this new department that we are putting together, you will see a lot of that. The ministry, we have a biostats department where we're collecting things, we're analyzing it, and that's what guide our action.
Mhm.
But
Okay.
Uh,
it is disease
Finally,
oriented.
I bring Dr. Ganga Johnson. But finally, in the data you collected, do you have it as one variable, ethnicity, as a variable in the data you collect?
I'm not sure. We'll have to check.
I think because of, in view of all the charges of discrimination, etc., by opposition forces, it's very important that data be broken by ethnicity. Okay, but let me go on to Dr. Ganga ask a final question.
yes, I just a quick comment here. In Guyana Watch, Dr. Tara led that group. We had several clinics, West Demerara, the Esquivo Islands, and so forth. And I was this front desk statistician. So I identified about five different areas where you have problems with the patients, their complaints. That's an important source of statistics. Let's feedback from the patient. This is bothering me. So the heart, the blood, and you cover that excellently. Um, the eye, but there were two other parts, heart, blood, eye. You have the stomach and you have the skin. So perhaps a very simplistic classification can lead to better diagnostics and treatment. So don't give up on from that source. That's an excellent source at the clinics, the front desk when they log in and they come. Well, what's bothering you? You shouldn't go to the doctor and say what's wrong with the doctor. Say what's wrong with you. I said, well, that's what is so I came here for you to tell me. But at the front desk, it's an excellent source of information. The other quick comment
Well,
is about diet and nutrition, which we didn't cover. But that education is important to lower long-term costs. We use too much oil. And the other thing, this is recent. I've seen a dentist. You can empower the doctor to contact the patient instead of having this impersonal app. It might overwhelm the system with the app. You have to bear that in mind. Let the doctor control that. Empower the doctor. Say, look, you have a direct relationship with the patient. We give you this phone here. You can contact the patient and adjust the schedule to suit. That's an important thing. I just did that before coming here. I missed my 1:30 appointment, and fortunately, the doctor said, "Okay, come after 4," and she was able to use her phone to make that adjustment with me. So patient doctor, from the doctor to the patient also is important. Okay, thank you very much for the opportunity, and very good.
All right,
Well,
Professor
one of the
Bulu.
things, though, just coming back to the uh, look, you have to listen to patients to get a better understanding of how to make that diagnosis. And for doctors, that's one of the source of forming a preliminary impression about what's wrong with the person. So it's absolutely essential that you speak with people and get a feel of what is going on with them before you proceed to do tests and all kinds of things, right? And that's part of our training because there's a methodology of what you do first, what you do second, examination, tests, and so forth. And I think that's important. What sometimes get missing these days is that people don't spend enough time to talk to the patient. So things that you can garner from a conversation uh, goes missing, and that can complicate the way that you make your diagnosis or your differentials and so forth. So that's something that we have to keep emphasizing. Despite technology, it is important that you maintain that human contact and understanding. I
All
think
right,
that's
Doctor Professor Bulu, a final comment.
Dr. Anthony, I think you and your government is doing a fantastic job in
thank you.
healthcare in Guyana, and very, very transformation is taking place. Final question I have for you. Guyana has a rich forest containing many medicinal plants. No, local Americans I know because I've worked in interior for a little while, have knowledge of these plants and treatments. Do you have any program to integrate these local treatments in the healthcare system?
Um, Not yet.
Mhm,
I think what we do right now, we have been using a lot of Western medicine.
mhm,
But as you would know, even with the WHO, the WHO last year opened a new center for alternative treatments
mhm,
in Gujarat in India,
mhm,
where there's now a WHO collaborating center, and where they'll be able to do more studies on some of these non-traditional methods of treatment.
mhm,
Um, and that's something we have to also explore because people's concept of medicine is it's changing, and the interventions that you can do is also changing.
mhm,
And therefore, as we understand how the body functions and what can keep people healthier, we have to keep an open mind and but back it up with the evidence. So a lot of this, some of it, if we might still have to do some studies to validate it
mhm,
before um, you can go out there and propagate it.
mhm,
So for us, what we know, it's backed up by research, and that's what we will be able to advise people because that's how we are trained,
mhm.
right? But these other things, there's nothing stopping us from doing the research to
Okay,
understand how these things
thank you
work.
very much, Doc. We've exceeded our time by quite a few minutes.
Okay,
If
sorry.
we really, I know the audience would have gotten a better grasp of the state of healthcare in Guyana and some of the challenges you face and how you deal with them. Now, I want to thank you very much for spending your time with us. And I also want to thank the panelists, Professor Manuram Budu and Dr. Ganga Ramdas. And well, actually, to the final statement, a 2 minute final statement you have to make. Generally, what message you have to send to viewers out there about their health?
For me, I just want to say to people that, as the president had promised when he came into office, that Guyana, we are building a world-class healthcare system, and we are making the necessary investments, both in terms of the infrastructure, in terms of the quality of the programs, in terms of the human resources. We are putting in the investments to be able to develop that world-class healthcare system. And we are already seeing the signs of that taking effect. But over the next couple of years, it would be even more prominent. And the dividends that we'll get from it would help the Guyanese people to live longer and healthier lives. And that
Mm.
is what we would like to see for our population, so that they can enjoy the prosperity that is coming on the economic side.
Thank you very much, Dr. Anthony. Your area is so vast. I think you have the second largest budget in the country. There's so many other issues which we couldn't really touch upon, but you have tried your best to give us a good perspective of where we stand with healthcare and the upgrades that you're going to do. So we want to thank you and wish you all the best in the coming years with the Ministry of Health. And I think there are lots of things we would like to talk about in more detail, like cancer, diabetes, and hypertension in particular. But we don't have time for that. And once again, I thank the panelists, Professor Budu, Dr. Ganga Ramdas, and yourself for educating us on the state of healthcare in Guyana. Good night to everybody, and good night to Shamiza.
Thank you.
Well, thank you very
Thank
much.
you. Thank you
Okay.
very much.
Bye bye.
Bye.